Good afternoon, everyone, and welcome to this month's compliance webinar. As we get going here, I am going to start by asking our audience a polling question. You should see that pop up on your screens here in just a moment. This month, we'd like to know how you feel about the sustainability of your company's health plan strategy. We know many of you had notable increases for your 2026 renewals, and we are curious how you are feeling about that as you're looking at your health plan strategy through 2027. So please take a moment and provide your feedback. And as you are doing that, I will cover a couple of items. And again, I'd like to welcome you to today's compliance webinar. I am Jenny Badeau with Assurex Global, and today the Loomlight team will be reviewing employer-sponsored coverage and Medicare. And the Loomlight team shared with me as we were chatting before we went live here that they field just a ton of questions around this topic. So we're certainly grateful that they're here today to provide some education and guidance. And we would like to extend a special thank you to your local benefits advisors and consultants who are partners of Assurex Global for making this webinar possible. And we do welcome your questions during the presentation. Please submit them using that Q&A function at the bottom of your screen, and we will address as many of them as time allows. And if you are just joining us here, I see we're getting quite a few folks still coming in. You'll see a polling question on your screen. Please take a moment and provide your response for us. And I will remind you too, our session is being recorded today. So if you are looking for a link to the recording after our session, you can receive that from that benefits advisor that invited you here today. That will be available the first part of next week. And they will also have a copy of those presentation slides as well. And I will drop a link to the presentation slides in our chat here in just a couple of minutes as well. And I'm going to keep our poll open. I still see quite a few responses coming in. And I'll give you a heads up that we have a related polling question that I will ask you during my closing comments. So please do be sure to stick around for my closing comments for that last and final poll. I'll give you kind of a sneak preview as I often do while we get our final responses here. It looks like the majority of you right now, about 2/3 of you are saying you're feeling some pressure. 17% of you are saying you're feeling like some significant changes are needed. But again, I'll let a few more responses come in and then we'll close that out. Okay, and thank you all for providing those responses. Here are those results. So again, just about 2/3 of you, or the majority of you, are saying you're definitely feeling some pressure, maybe looking at adjusting some of your strategy through 2027. So again, thank you for providing those responses. Definitely appreciate that. And for now, we will get moving into today's content. So joining us from the Loomlight team, we have Regan Debin, who is Director of Compliance Consulting, and Amanda Olam, Senior Consultant. So Regan and Amanda, thanks for being here. I will turn things over to you.
Thanks, Jenny, and thanks everyone for having us here today. Excited to address this with you. This is something that we're seeing so many questions on, and not necessarily that the rules have changed on us, but I think the reality is just so many more employers are seeing older individuals remain active in the workforce, and so then facing kind of how to navigate when they become eligible for Medicare while they're still potentially able to enroll in the or remain enrolled in the employer's plan as well, or even as they're kind of going through the transition and it's close to the same timing when they're transitioning maybe either to COBRA continuation, or if they have retiree options available while they're also eligible for Medicare, what does that mean and what types of decisions should they be making? So decisions for the employees to be making, but then also quite a few compliance rules where Medicare can potentially impact how the employer needs to be administering their plan. So, what our plan is today is to first take you through some Medicare basics. And I'm going to tell you right up front that I am not an expert in Medicare coverage as far as kind of costs, ultimately, what coverage it makes available to individuals. But what we're going to talk about is just the basics around when it can go into effect, when it's available to individuals. And then ultimately, there are options around potentially delaying that coverage and avoiding late enrollment penalties. That's really going to be our focus today. After I go through that, then we'll shift and jump into the compliance considerations, and you can see them all listed there. And then finally, at the end, appropriately, we're going to wrap up with deciding when to enroll in Medicare, kind of putting all of those pieces together and walking you through different employees in different situations, whether it's a small employer or a large employer, whether it's active coverage versus COBRA or retiree coverage, what their options are, and how to navigate that. And for you to be able to know, not necessarily your responsibility as the employer to tell them exactly what they should or shouldn't do. And sometimes that's going to vary depending on their circumstances. But the reality is that employees look to you to help them navigate some of that. And you're certainly fielding questions around that. We know because they're coming our way as well. And so hopefully this will provide a good basis for you to be able to better assist with that. And then, of course, the broker partner that invited you here today would be able to provide much broader assistance for you. So, as we're going to go through a lot of information today fairly quickly and hopefully help you issue spot and kind of understand the types of things that you need to think about for your plans, very appropriate for then you to go back to the broker partner that invited you here today if you have further questions or want to make sure that you understand how this works for your plans and for your participants. With that, we'll go ahead and jump into Medicare basics. And then Amanda's going to be available, as Jenny mentioned. Please submit questions and comments as we go through today. She's going to be watching that and jumping in as I go through the content today to try and address as many questions as we can and to redirect me if we need to kind of revisit some of the things as we go through the different topics. Starting with Medicare basics, there are three main ways that individuals can become eligible for Medicare. The first is age-based. That's probably the one that we run into most often. Once individuals turn 65, then they are eligible for Medicare just solely based on their age. Another way that individuals can become eligible for Medicare at any age is if they're determined to be disabled by the Social Security Administration. So that's a very specific process that they go through and submit information and get that formal determination of disability from the SSA. But then if they receive that, then they can become eligible for Medicare based on that disability. And then the third one is end-stage renal disease. So we will often say ESRD-based Medicare, and that's what it's referring to, that end-stage renal disease, that's another way that Medicare eligibility can be triggered kind of based on when they may start dialysis in connection with that diagnosis. And then finally, an informal one, but I don't want to leave it off the list. We often just think of these three types, but ALS is another condition that can also trigger Medicare eligibility. So three different groups of individuals that could potentially become eligible for Medicare. Important for you to know as an employer so that you're not just thinking of individuals age 65 and older, but that there may be other individuals, other employees, or perhaps their spouses and dependents who you would be less aware of their circumstances, but they could potentially be eligible for Medicare, for example, because they've been determined to be disabled. Really important to set kind of a baseline because it's going to matter for a lot of the different compliance things that we talk about is that there is a difference between Medicare eligibility and Medicare entitlement. Merely being eligible for Medicare, you are not always automatically enrolled in Medicare, or at least not all parts of Medicare. It will depend on the individual's circumstances. So they can be eligible for Medicare and not actually have Medicare coverage until they take action to formally enroll. Once they actually enroll and the Medicare coverage is available and in effect, then it's called Medicare entitlement. So I just want to, before we even get started today, make sure that you know that those are two different things. And as we go through, I'll try and clarify whether what we're talking about is tied to if they're just merely Medicare eligible or if it's tied to Medicare entitlement once that coverage is actually in effect. There are different parts of Medicare, so we're going to talk about the main ones and focus, like I mentioned, on the effective date and when they can potentially enroll. So the first one is Medicare Part A. The effective date for Medicare Part A, if they enroll when they're initially eligible, they can have coverage go into effect as early as the month that they turn 65, or if their birthday is on the first of the month, it will go into effect the previous month. That would be the earliest that they would have access to that coverage. If for whatever reason they decide to delay Medicare Part A enrollment, something that's important to understand is that they can enroll at a later date, but it may be retroactive up to 6 months. It's never going to be earlier than the month of their 65th birthday, but depending on when they enroll, it could go back up to 6 months. And so that's important for individuals to understand that that may just happen automatically. As far as enrollment, for Medicare Part A specifically, it might automatically go into effect for individuals who are eligible for Medicare or for age-based Medicare. If the individuals are already receiving Social Security benefits when they turn 65, Medicare Part A enrollment is automatic. The individual doesn't have any choice. Those two things go together. But it is possible for individuals to delay starting to receive their Social Security benefits. And if they choose to do that, then when they turn 65, Medicare Part A isn't automatic. Then they would have to take steps to go ahead and enroll in Medicare Part A. So they do have a choice depending on whether or not they're already receiving Social Security benefits. For Medicare Part B, the effective date is similarly the month that they turn 65 if they enroll right away, or if they decide to delay it for whatever reason. Medicare Part B isn't retroactive. Whenever they then enroll in the future, it's going to be effective the month after the individual signs up. As far as the options to delay Medicare Part B, individuals can delay enrollment. Their enrollment is not going to be automatic. But if they don't have other creditable coverage, they go more than 8 months from losing creditable coverage, then they will face a late enrollment fee when they do sign up. And then that would be permanent going forward. So it would just always cost them more for the remainder of the time that they have that Medicare Part B coverage. An employer's group health plan can count as creditable coverage if they have that coverage based on active employment status, either the individual's active employment status or that of a spouse. We do have to be careful for really small employers with less than 20 employees. Their group health plan coverage may not be creditable based on how that's structured, and we'll talk about that a lot more in a bit. And then we also have to understand it is tied to current employment status. So COBRA or retiree coverage would not be creditable for this purpose. That would not be something that they could enroll in COBRA and then delay Medicare Part B. The penalty if they do delay without creditable coverage and go too long is that there would be an additional 10% added to the monthly premium for each year that the individual delays enrollment without other creditable coverage. And the final one we're going to touch on today is Medicare Part D, and this is the prescription drug portion. Very similar to Medicare Part D, if they enroll right away when they're first eligible for Medicare, they could enroll as early as the month that they turn 65 for age-based Medicare. If they delay and enroll later, it would be the month after they sign up. It is also possible to delay here, but the rules about delaying are different than Medicare Part B. It's a little bit confusing because we talk about creditable coverage in both situations, but creditable for Part B is just based on active coverage tied to current employment status. For purposes of Medicare Part D, creditable coverage is tied to what prescription drug coverage is available via the plan and whether it's as good or better than Medicare Part D. And we're going to talk about that in much more detail as well. But if individuals do have access to creditable prescription drug coverage, they can delay Medicare Part D. If they go more than 63 days without creditable prescription drug coverage, then they'll face a late enrollment penalty when they do eventually decide to enroll in Medicare Part D. And then we've got the penalty there. It's 1% added to the monthly premium for each month that they go without non-creditable coverage. So we do really have to be careful. For individuals, this can really matter whether they are timely enrolling in Medicare. They don't want to delay and end up having very significant premium penalties that they will have to keep. That cost will just be increased for them for the duration of the time that they're on Medicare. So with those basics in mind, I want to jump into the different compliance considerations for you as the employer that can potentially impact how you are administering your plan, but then also will play into ultimately some of the things that I was just talking about and the choices employees have to make when they are both eligible for Medicare as well as potentially eligible for your employer-sponsored plan, either as an active participant or as a COBRA participant or retiree participant. The first one that is pretty important are the coordination of benefit rules that we get from CMS. They're called the Medicare Secondary Payer Rules, the MSP rules. These rules govern for all plans for individuals who are enrolled in both an employer's group health plan and Medicare simultaneously, which plan is the primary payer. And I first want to start and clarify that that is possible. Individuals can absolutely have both the employer-sponsored plan and Medicare in both cases, at least for larger employers. So they can have that dual coverage, and then what happens is one of the plans is the primary payer, and the expenses get run through that plan first, and it pays according to the normal cost sharing under that plan. And then with whatever is left over, before the participant would pay anything, then they would run it through their secondary plan, and that plan would pick up and pay a little bit more, potentially all of it if they're lucky, and depending on how rich those two different plans are. But then ultimately, whatever's left over after it's run through the secondary plan, that's what the participant would have to pay. So these are the rules that we follow. It's going to depend what type of Medicare triggered, why they're eligible for Medicare in the first place, and also the size of the employer. And you can see the chart there. For the smallest employers, less than 20 employees, so that's a pretty small employer, for whether it's age-based Medicare or disability-based Medicare, the employer's plan is always going to be the secondary payer, and the Medicare is going to be the primary payer. For employers in the 20 to 99 range, for age-based Medicare, their group health plan is going to be the primary payer. Medicare would be secondary. But for disability-based Medicare, that threshold is a little bit higher. So if they're less than 100 employees, then the employer's plan would be the secondary payer and Medicare would be the primary payer still. If you have 100 or more employees, then whether it's age-based or disability-based Medicare, your group health plan is always going to be the primary payer to Medicare. I didn't mention the ESRD-based column. We've got a unique set of rules there. Regardless of size, the employer's plan is always going to be the primary payer for the first 30 months. Now, those were all tied to, you can see at the top of the table, it's labeled active plan participants. If instead we're looking at retiree or COBRA participants, Medicare is always the primary payer. And the group health plan, if they decide to elect COBRA or retiree coverage, would be the secondary payer. That's why in a lot of cases, it's not going to make a lot of sense for them to keep that retiree or COBRA coverage because Medicare would be the primary payer. Again, we have the same exception for ESRD-based coverage, however, even for retiree or COBRA participants, the employer's group health plan is going to be the primary payer for the first 30 months, and then Medicare would pick up and be the primary payer as of the 31st month. A lot of employers look at this and ask, well, how does this even get enforced? Or how does CMS make any sense of this or know if an employer's plan is paying primary when it should? Or how do they catch it if individuals make mistakes and they've got dual coverage, but they go and they have care and they only submit insurance information for the employer's plan or just for Medicare? This is where the MSP mandatory reporting comes in. Employers aren't required to do this mandatory reporting. Your carrier or TPA should be doing this quarterly on your behalf, but they have to go through and they have to provide a census with information about who's eligible for Medicare or who's not and who's covered in the employer's plan or not. And CMS is actively using this information. And if they see that they've paid claims for certain individuals as the primary payer and they think there's a reason that they shouldn't have, the plan will often get a letter either from CMS or they've got some third parties that work on their behalf, and they'll reach out and say, hey, for this individual and these claims, we paid primary and we don't think we should have. So we're asking for this amount of money from you unless you can show us, that they weren't enrolled or, that you don't think you should have been the primary payer. And there's room to appeal and have that conversation. But this is actively being enforced and reconciled as appropriate. When the employer's plan is the primary payer, we have to follow certain rules under MSP because they don't want the employer then pushing employees toward Medicare when the employer's group health plan has responsibility to be the primary payer on claims that come through. And so these are the kind of the three main rules under MSP when your group health plan is the primary payer. So for sure, for those of you with 100 or more employees, you're following all of these rules. You're prohibited from taking into account the Medicare entitlement of the employee or the employee's family members that are covered under your plan. So you can't charge them something different. You can't change the level of benefits that are available. You have to treat them just like you would anybody else who's covered under your plan. Similarly, for those who are age 65 or older, whether it's the employee or the spouse, you have to give them the same benefits under the same conditions as is provided to younger participants. So those are kind of related. The third one is the one that we run into perhaps most often, where a lot of employers look at these individuals who are eligible for Medicare, especially age-based, where they know that that's the case, and they're saying, well, what can we do? How can we move them to Medicare? Can we give them money to go somewhere else? Can we help pay their Medicare premiums? Can we give them some type of an opt-out incentive? And the answer is no. The rules are really specific that we are not supposed to be directly or indirectly incenting those individuals to move to Medicare instead of enrolling in the employer's group health plan. It's fine to provide general education about their Medicare options, but then ultimately we have to leave that decision up to the employee or their family members and let them make whichever choice makes the most sense for them. And if they choose to enroll in the employer's plan instead, there shouldn't be any consequences for that. There are some significant consequences for not complying with these rules. The civil penalty is pretty low, just $5,000 per violation, so not a huge deal. But if a plan was audited, or if ultimately there were some complaints from an individual who felt that they got pushed off the plan and didn't get the coverage that they should have, the government could impose a penalty of up to 25% of the employer's expenses that were incurred during that calendar year. Switching to Medicare Part D creditable coverage. This is any group health plan that provides prescription drug coverage has to consider whether that coverage is creditable or non-creditable. The employer doesn't have to offer creditable coverage. There's no penalty if the plan is ultimately determined to be non-creditable. The employer, though, is responsible to make that determination and then communicate that to eligible participants for their or eligible individuals for their plan, as well as to CMS each year. I mentioned before, creditable coverage is when the actuarial value is equal to or exceeding what's available via Medicare Part D, and that has been increasing over the last couple years. So the bar is going up as far as what level of coverage has to be available to be as good or better than Medicare Part D. I should also mention that the prescription drug coverage we have to look at, it could be part of the group medical plan. That's probably the case most often. And then we just look specifically at the prescription drug coverage that's available. It might also be available as a separate plan that's kind of integrated with the group medical plan. Either way, we're going through the same analysis. Ideally, you've got a carrier or TPA that is helping with this determination, and they're just letting you know, we've already looked at this and we've determined that your coverage is either creditable or not. But if they don't do that for you, then it is your responsibility as the employer plan sponsor. And so then your options are either to obtain an actuary. Sorry, I didn't mean to bump that yet. Obtain an actuarial analysis from an actuary, or use the simplified determination method that CMS has given us. And so that's what I have here on this next screen. We've got two different ways. What they basically gave us for the first time back in 2009 is this different criteria that if you can look at the plan and say it meets this criteria, you can assume that the prescription drug coverage is creditable. So I'm not going to go through that. I'll leave that there. The main reason why I have the details here is that just last year they gave us a revised simplified method. So they'd left it alone for almost 20 years. And then in response to the increasing level of coverage available via Medicare Part D, they gave us a revised simplified method. And for the first year that they rolled this out for 2026 plan years, they said that we could use either one. We could use the old method if we know what that is and we already know our plans are creditable or not and rely on that, or we can switch and use the new revised simplified method. We have not gotten the final rules yet for 2027, fully expecting those to be out in the next month or so, so very soon. But we're guessing that what they're going to say is that we can't use the original simplified method anymore. We have to move to the new simplified method. The main differences there are just you can see in the first bullet point that it's not just coverage for brand and generic prescriptions, but biological project products as well. I'd say that a lot of plans have already moved to that anyway. The other kind of key change is that instead of a 60% or better actuarial value, plans have to hit 72% or better actuarial value. So it's just bumping up that threshold. It is possible that then using this new simplified method, we'll have more plans that are non-creditable. So then I just want to remind you that's not non-compliance. That's not necessarily an issue for you as an employer, but it is potentially an issue for those individuals who are both eligible for Medicare Part D and eligible for your prescription drug coverage. They have to understand then that they can't rely on your plan anymore to delay Medicare Part D if that's the case. So how do they find out? How do they know? Remember, the other piece that I said is that you are responsible for making the determination, but then also communicating to eligible individuals whether your plan is creditable or not, as well as letting CMS know each year. So we have to provide these creditable or non-creditable notices. We've got templates from CMS for this purpose that we use. Let them know that the plans are creditable or not when they're first eligible for your prescription drug plan, as well as annually. You can do that either during your open enrollment as part of your notices packet, or a lot of employers do it each fall to align with Medicare's open enrollment. Either one is okay as long as you're sending it out annually. And then the second piece is you fill out an online electronic disclosure form for CMS. It's very simple and straightforward, just takes 5-10 minutes if you've got all your plan information at your fingertips. But you're supposed to do that each year within 60 days of the start of your plan year. And then just letting them know these are our plans, plan number, these are the different options that we have available. Give them some information, some estimates about how many Medicare eligible individuals you may have on your plan, and then let them know whether your plan options were determined to be creditable or non-creditable. We often get questions because this is the responsibility of the employer to handle these pieces, both the disclosures to individuals as well as reporting to CMS. What if we didn't? What if we didn't do this? There aren't any specific penalties tied to this. We don't see employers necessarily getting penalized for not doing either one of those pieces unless they are taking advantage of the government's retiree drug subsidy. Then you can lose that if you're not complying with these notice requirements and reporting requirements. But perhaps what's more important here is going back to why are we sending out this information? It's to let the individuals who are eligible for your plan make an informed choice and avoid those potential late Medicare Part D penalties. They need to know when they're choosing whether to enroll in your plan or move to Medicare or have dual coverage, whatever they decide to do, whether they're okay doing that. If they have creditable coverage, they can. If they don't and they go more than 63 days without this creditable coverage, then they'll have those late enrollment fees later. I'm going to pause there for just a moment. Amanda, is there anything before we jump into the next topic that you want to address? Got kind of a theme or any questions?
Um, it's basically we're kind of focusing more just on how Medicare itself functions, what each part actually covers, when it would be appropriate for a specific individual to enroll. And I will say that we are focusing mainly today on kind of how we interact with employer-sponsored health plans. I think we've done a pretty good job of answering them so far, but some of those more specific Medicare questions might be better directed to a Medicare specialist. So,
And certainly a good idea to have that available, or have a resource that you can direct employees to, because that is really important. There are a lot of options and around Medicare, the different parts, whether they want to do, kind of the traditional A, B, and D, whether they want to go with a Medicare Advantage or a Medicare Part C plan, if they want to have supplemental coverage. We're not getting into any of that today, but it is hugely important for them, and they likely should have help navigating that. So having someone that you can refer them to, or that can come in and do some general education as appropriate on their options, would be a very good thing. That's just
And I
not.
will just piggyback slightly on that. The other question being, are we expected to be communicating all of these primary versus secondary points with them? And there aren't really any actual requirements for an employer, but we do believe that providing this education to your employees is a good idea so that they aren't caught out with gaps in their coverage, right?
Mhm, mhm. Yeah, and depending on your size, that's easier, right? If you're a larger employer, you can always assume, our plan's always going to be the primary payer. So if individuals say they're going to do that and Medicare, it's like, well, that's fine if it's worth paying premiums for both. But just know that the employer's plan is going to be the primary payer so that they can plan accordingly. We're going to talk about in a bit, when it's a small employer, some of the options that they have, and then it's perhaps even more important to be communicating, whether they're still eligible or whether it's only secondary coverage available to them. That's going to potentially make the decision for them as to whether they should be moving to Medicare sooner rather than later. All right, COBRA continuation. This is something that it both can be a qualifying event and trigger continuation rights tied to Medicare, and then it also can affect the maximum coverage period. So we're going to talk about both of those things. Remember that federal COBRA is triggered for those employers with 20 or more employees when there's a loss of eligibility, a loss of coverage tied to one of the events listed there. We've got 6 different bullets. So it's a specific list. These are the events that would have to happen tied to a loss of coverage. And when those two things get put together, it triggers a COBRA continuation right for the individuals who lost the coverage. I've got highlighted there that one of the events is the employee's Medicare entitlement. That being the case, this is a place that causes so much confusion, and I almost wish this wasn't even listed as an event because it rarely actually causes a loss of coverage. If you go back to the MSP rules that we talked about when we started off the compliance discussion, remember that employers whose group health plan is primary, you have to continue offering the same level of coverage to those who are Medicare eligible. You can't exclude them. You can't adjust the coverage levels available. You can't adjust the cost and make it more for them. So it doesn't cause a loss of coverage when those individuals enroll in Medicare. They can actually have dual coverage and keep both for a period of time if they want to do that. What often happens, however, is that when individuals become eligible for Medicare, they voluntarily choose to drop the employer's plan and move to Medicare. And if they make that choice, a voluntary termination of coverage by the employee doesn't trigger a COBRA continuation right for the spouse's independence. So even though they're losing coverage, it's a voluntary loss of coverage that doesn't trigger a COBRA continuation right. So except for the smallest employers that may have eligibility rules in place that say when someone enrolls in Medicare or is even eligible for Medicare that they lose eligibility for the employer's plan, that's the only place where it would actually trigger a COBRA continuation right for the spouse independence. For that reason, when employees are making this decision about whether to stay on the employer's plan or move to Medicare, if they have spouses and dependents that still need that coverage under the employer's plan, they might have to stay with the employer's plan or maintain dual coverage for a period of time to keep that active coverage available for their spouse and dependents. Then I mentioned it also affects the maximum coverage periods. It affects the maximum coverage periods differently depending on whether the individual is entitled, remember, actually enrolled in Medicare, not when they become eligible, but instead when they actually enroll in Medicare. And if that happens after they elect COBRA, or if it happens before they elect a COBRA. If it happens after they elect COBRA first, and then later they enroll in Medicare. COBRA coverage can be terminated for the individual that enrolls in Medicare. That can cut short the maximum coverage period. But it's important to note that for other family members that may have also elected COBRA, it won't affect their maximum coverage period. They can continue. If instead the employee elects Medicare or enrolls in Medicare and they maintain dual coverage for a period of time, and then later they have a termination of employment or reduction in hours and they elect COBRA, in that case, it doesn't get cut short. For that, in the employee, the COBRA coverage would still have to be available for the maximum coverage period. And in addition, it triggers the special extension rule for the spouses and dependents. They get the greater of 36 months from whenever that Medicare went into effect, or 18 months from the qualifying event, whichever is greater. And I've got a couple examples to go through both of these things. First, we'll look at when Medicare entitlement happens after a COBRA election. In this example, we've got an employee who retires in July of this year. And then the retiree turns 65 in mid-March of next year and enrolls in Medicare at that time. The retiree's COBRA coverage then is going to terminate upon Medicare enrollment, but the family's COBRA coverage can remain available for 18 months. So you can see down at the bottom then we've got a timeline. That retiree is offered COBRA upon retirement and would be able to continue that for up to 8 months. And then when they move to Medicare, that would get cut off. Whether they want the COBRA coverage anymore or not, they wouldn't have that option if the plan chose to cut it off. But for the family members, for the spouse and dependents who also elected COBRA following the employee's retirement, they would have all the way up through January of the next year. If instead we have the Medicare enrollment first and then later the COBRA qualifying event, then we've got these little bit different rules. So in this example, we've got an employee who enrolls in Medicare in August of this year, remains enrolled in the employer's group health plan too. So they have dual coverage starting in August of 2026 up until they retire in January of next year. At that point in time, the retirees offered COBRA for up to 18 months. We can't cut it short because the Medicare entitlement came first. And then we also trigger that special extension for the family. So the spouse and dependents would have to be offered coverage for up to 36 months from August of 2026 or 18 months, whichever is greater. In this particular case, only 6 months of that had already expired when they were offered COBRA, so they would get up to 30 months if they wanted to continue the employer's group health plan via COBRA. Switching to cafeteria plans, most of you allow your employees to make pre-tax contributions through a Section 125 or a cafeteria plan. And so we've got just a couple things that we have to think about tied to Medicare there. First of all, I want to point out Medicare premiums typically can't be paid pre-tax through a cafeteria plan. So that's a question we often get. If you've got employees who waive the employer's plan because they enroll in Medicare instead, then the question is, well, could we pay for those pre-tax through the cafeteria plan? It violates a couple different rules doing that. First of all, it can be seen as a prohibited incentive under MSP rules. It also can be viewed as a prohibited employer payment plan under the ACA rules, and then it can cause other discrimination issues and things too. So just stay away from that. Don't allow employees to pay pre-tax for their Medicare premiums through your cafeteria plan. Health FSAs, I threw those in here because they fall under the 125 rules as well. There is a strict prohibition. They are available broadly to reimburse any qualifying medical expense. An insurance premium could fall under that, but under the Health FSA rules, it very specifically says any qualifying medical expenses other than insurance premiums. We can't use a Health FSA to reimburse insurance premiums, so we shouldn't be using the Health FSA to reimburse Medicare premiums either. Then the final thing I want to touch on here is related to election changes. We have this come up all the time where individuals either become eligible for Medicare mid-plan year or lose eligibility for for Medicare mid-plan year, although admittedly that happens less often. But when that happens, the Section 125 election change rules that say once you've made an election, you're stuck for the plan year unless you have a recognized change in status or life event. Enrollment in or loss of Medicare eligibility is specifically recognized under 125 rules as allowing a mid-year change. So individuals who come forward and say, I enrolled in Medicare, it's effective next month, I'd like to drop the employer's plan, is that okay? And the answer would be yes, as long as they meet your time frame for providing that notice or making that request, you can allow them to drop your plan and move to Medicare mid-year. Or if they have a loss of Medicare eligibility and you allow them to enroll in your group health plan mid-year, they would be able to adjust their pre-tax elections accordingly under 125 rules. I mentioned Health FSA under the 125 rules, but we also have quite a few things that are impacted for health savings accounts or HSAs that are tied to Medicare as well. One of the main things being that Medicare is a type of disqualifying coverage that causes a loss of HSA eligibility. Really important here, just like it was important for purposes of the COBRA rules, eligibility for Medicare doesn't affect HSA eligibility at all. Somebody who is merely eligible for Medicare but delays enrollment can maintain HSA eligibility as long as they still have that HDHP coverage and they don't have any other disqualifying coverage. So common misnomer is that individuals turn 65 and they automatically lose eligibility for their HSAs, and that's not true. They can maintain eligibility as long as they delay Medicare enrollment. If they enroll in any part of Medicare, even if they're just automatically enrolled in Medicare Part A and they leave the rest until later or delay enrollment in the rest until later, that causes a loss of HSA eligibility. So if they have any part of Medicare that goes into effect, they are no longer eligible to contribute to an HSA. I want to be careful here to differentiate between eligibility for the employer's HDHP or high deductible health plan option versus HSA eligibility. Your eligibility for your HDHP is just going to be tied to your eligibility rules. So they might still be eligible and able to continue participating in the HDHP, even if they enroll in Medicare. And like we described, they could potentially have dual coverage, but they would lose their ability to contribute to an HSA. If they lose eligibility to contribute to an HSA, it affects ultimately the amount that they're able to contribute to an HSA for that year. But it's done on a prorated basis. Individuals can contribute up to 1/12 of the annual limit for each month that they're eligible to contribute to an HSA. It also doesn't impact when they can make those contributions. So just because an individual loses eligibility to contribute to an HSA mid-year, that doesn't mean that they can't make any further HSA contributions. They have all the way up until April 15th of the following year, their tax filing deadline, to make their prorated contributions for the year. I'm going to go through an example of that in just a moment. But before I do that, I just want to point out that even once individuals lose eligibility to contribute to an HSA, they hold on to whatever funds they've already contributed to the HSA, and those funds are available indefinitely for the account holder and expenses that are incurred by their spouses and tax dependents for any qualifying medical expenses until they're exhausted. When they lose HSA eligibility, what they're losing eligibility for is the ability to put more into it, but they don't lose what's already been contributed. So this is the example that I mentioned. We've got the annual contribution amount, and we take that times the number of months that the individual is eligible divided by 12, and that's how we get the individual's prorated contribution limit for the year. So if we have an individual who enrolled in single HDHP coverage at the beginning of this year, but then they enroll in Medicare in August of this year, or that's when their Medicare goes into effect, they were then HSA eligible for 7 months of the year. So we would take $4,400, which is the single contribution limit for 2026, times 7/12, and that individual then is eligible to contribute $2,566.66 for 2026. And they don't have to make that full contribution by August 1st. They can make that contribution or up to that contribution amount anytime between January of 2026 and April 15th of 2027. This causes a lot of confusion for employers because they'll get really worried about, we didn't understand that somebody, enrolled in Medicare. They didn't tell us until 2 months later, and we didn't stop the contributions. Maybe the employer was still contributing. Maybe they were still allowing the employee to contribute pre-tax through their cafeteria plan. That's not necessarily a problem. So long as they haven't gone over their prorated contribution limit, they may be just fine. If they did go through over their prorated contribution limit, maybe they did a lump sum contribution early in the year, then it would be up to the individual to correct that and to ask for a curative distribution to avoid potential taxes. Final thing on HSAs, I want to talk about things that are reimbursable under the HSAs. Very similar to an FSA for the most part. HSAs are available to reimburse qualifying medical expenses, but not insurance premiums. But then the HSA rules give us some exceptions. For individuals, I've got them all there, but the one I care about today is for individuals age 65 or older, they are allowed to submit in Medicare premiums for reimbursement. So Medicare premiums for those 65 or older are reimbursable by an HSA. Switching to our final compliance piece here, HRAs or health reimbursement arrangements, we often get questions from employers about whether or not they can reimburse Medicare premiums via an HRA arrangement, whether they're setting it up specifically for Medicare reimbursement or if it's part of a broader HRA reimbursement structure. For a lot of the reasons that we've already talked about, this is typically a problem to do that. It would violate MSP rules because if they're helping reimburse those Medicare premiums, at least for active employees, it's an incentive for them to move to Medicare instead, which is not allowed. It also can create an ACA prohibited employer payment plan to reimburse individual premiums, which would include Medicare premiums. So for most employers, it's not going to work, at least for their active employees, to reimburse Medicare premiums via an HRA, but we do have a couple exceptions. One is retiree HRAs. In that context, it's okay because it's as long as there aren't any active employees that are able to take advantage of that HRA. If it's truly all retirees, it would be okay to reimburse Medicare premiums. And then we have two exceptions that are a little bit newer that came about, I think, in 2020-ish. Two different options, an individual coverage HRA or a qualified small employer HRA. And I'm going to talk about those two a little bit more on the next couple slides. But then the final exception is for a small employer. Because remember, your plan is always going to be the secondary payer. So it wouldn't violate MSP rules to provide Medicare reimbursement. And then the IRS has given us some rules that say if we structure it in a particular way, it can also avoid violating the employer payment plan rules under the ACA. So for most employers, we can't do this. If you're a very small employer and you have your HRA structured a particular way, then you may be able to provide that Medicare premium reimbursement. When we think about individual coverage HRAs or ICHRAs, these can be offered by employers of any size. They can be offered to a portion of the population, or it can be offered to all eligible employees. It is funded solely with employer contributions, and it can only provide reimbursement to those who are enrolled in individual health coverage or Medicare, so it's not tied to a group health plan in any way. And we can't offer employees a choice between a traditional group health plan and an ICHRA. They get one or the other, but they can't have a choice. And then the final piece, and that's what we're really focused on for purposes of Medicare, is that we have to offer uniform ICHRA funding and coverage to all employees within a specified class. And the permitted classes are listed down at the bottom. You can see Medicare is not a permitted class. So it isn't possible to say, okay, well, we're going to take all of our Medicare eligible individuals and offer them an ICHRA, and then we'll offer the rest of our employees a traditional group medical plan. That doesn't work. What you could potentially do is you can mix and match these classes of employees. So you could potentially say, we're going to do this for our full-time salaried employees working in a particular location to really carve it down and still fit within these permitted classes. And perhaps most of your Medicare eligible individuals then, fall within that class, and that would be okay. But we can't do it just specifically for Medicare eligible individuals. The qualified small employer HRA is another type of HRA that can provide reimbursement for Medicare and is potentially tied to Medicare enrollment. This one is a little bit more strict because it can only be offered by small employers with less than 50 full-time equivalents. And it can only be offered by small employers who don't offer a traditional group health plan at all. So this would be completely instead of offering a group medical plan. Does have to be provided uniformly to all employees. So again, there's no chance that an employer could structure this to be available solely to those who are Medicare eligible. It can be integrated, though, a little bit more broadly than an ICHRA. It can be available to those with group health plan coverage, with individual health plan coverage, or with Medicare. So a little bit more flexibility there. A little bit less flexibility in regard to funding. The ICHRA doesn't have any funding limit. The QSARAs do have a funding limit based on whether they're enrolled as a single individual or as a family member. So with that, Amanda, I think I'll take us through kind of this last section. We've got just a couple slides on helping individuals kind of navigate when they should be enrolling in Medicare or staying in the employer's plan, and then we'll take some final questions before we wrap up today. So small employers, taking everything that we've been talking about so far, let's assume that the employer's plan is secondary. So think of just our smallest employers that are with us today with less than 20 employees, where your plan is always the secondary payer. You have the option to potentially exclude Medicare eligible individuals completely. Your eligibility rules might say full-time employees who are working 30 or more hours per week, but not Medicare eligible individuals. You could potentially do that. That's not super common. What we run into most often is that employers instead have what's called a Medicare estimation clause, and you might not have any choice about this. This may be something that your carrier has decided that they're going to put into all of their small group health plan offerings. Again, called a Medicare estimation clause is what they refer to this as, and what it says is, we will allow you to stay on the plan if you are eligible for Medicare, but we will only pay as a secondary payer. And that's true whether you enroll in Medicare or not. So if you delay Medicare enrollment and only have the employer's plan, it's going to process any of your claims as if you only have secondary coverage, really leaving a significant gap and very limited coverage available to individuals. So I know, Amanda, you fielded the question earlier about, is there any responsibility to let people know about primary, secondary payer status? Maybe not directly, but certainly if your plan has a Medicare estimation clause in it, you need to know about that and make sure that employees know about that so that they can probably, right away move to Medicare, or they really don't have substantial coverage. So for small employers, very small employers, when employees become eligible for Medicare, they probably need to move to Medicare right away to avoid very limited coverage or late enrollment penalties. But in this case, you as the employer are also able to provide an HRA and provide that Medicare reimbursement to some extent if that's of interest to you. For large employers, let's assume the employer's plan is the primary payer. We're assuming active coverage here for current employees. The employee has a lot more flexibility. They could delay Medicare enrollment, they could drop the employer's plan and move to Medicare, or they could potentially have dual coverage, which I know I talked about quite a bit as we were going through the different rules today. When they're making this decision, it's really going to depend. What coverage do they have available via the employer's plan and how much does it cost versus what would be available via Medicare and what would that cost? So they're just going through that analysis. But then they're also thinking about things like, do I want to continue contributing to an HSA? I'm using that as a retirement vehicle. I get a large HSA contribution from my employer. That may be a reason that they want to maintain the employer's HDHP and delay Medicare enrollment. They may also need to maintain coverage for their spouses and dependents, and they've got rich coverage available on the employer's group health plan, and they don't want to lose that for the spouses and dependents. So they decide to stay in the employer's plan or potentially maintain dual coverage. So a lot of things go into this as far as what's the right decision for a particular individual if they really have the option to stay or go or have dual coverage. Then finally, for retirees or COBRA participants, remember in most cases other than ESRD-based Medicare, retiree or COBRA coverage is always going to be the secondary payer. So it could potentially exclude those who are Medicare eligible or cut short their COBRA coverage period. This is also another place where we see the Medicare estimation clauses, and we run into that a lot. And employers may or may not know that they've got that in their plans, where it will say, if you only have retiree or COBRA coverage, not active coverage, we will only pay as the secondary payer, regardless of whether you're actually enrolled in Medicare. So similar to the very smallest employers, when individuals are choosing between Medicare and retiree coverage or COBRA, they're really better off in most cases moving to Medicare sooner rather than later, both to avoid limited coverage as well as late enrollment penalties. For retiree coverage, the family members might be able to still keep that, or that would potentially trigger a COBRA continuation right for the retiree coverage for the family members. Also, if they're enrolled in COBRA, remember the retiree moving to Medicare is not going to cut that short, so they would have the right to continue COBRA as well. With that, Amanda, anything that we want to touch on and wrap up before we turn it back over to Jenny for our final
Um,
polling?
We did get a request to just quickly look again at just the general MSP, who pays first
Mm-hmm.
side, and just kind of maybe talk through that just slightly.
Let me see if I can do that without fumbling around
Yeah.
too much for you. Oh, let's see. It was toward the beginning.
Hmm.
There we go. Go ahead. Amanda, do you want to take a
Sure.
stab at
Yep.
it just for a
Yep.
different voice, different overview?
No problem. Yeah. So, I think the first thing here that you got to do is you got to ask, why are they entitled? Why are they entitled to Medicare? So that's the first thing. If we're talking about age-based, the only time that the group health plan is not going to be primary is if they're under 20, right? When they're talking about disability-based, we're moving that up to 100 if they're under 100. So if you have an employer that has 100 or more employees, they're always going to be the primary payer for both age and disability based. And then for ESRD, we've got slightly different rules. The group health plan is going to be the primary payer for the first 30 months, right? Then we'll switch to Medicare. And then finally, all of those rules are specifically for active employees only. If the coverage is because of retiree coverage or COBRA, then Medicare is going to be primary for both age and disability based, but we're still left with that ESRD rule about the first 30 months being the group health plan as primary.
Perfect. All right. Well, with that, I think we've gone through probably enough for you to digest today. We'll turn it back over to you, Jenny, and just encourage you. We probably triggered questions for you today more than anything. So just definitely appropriate to reach out and get some help with this depending on your employer size and look at your particular plan terms and just make sure that you've got everything where you need it to be and can answer questions for your employees.
Great. Thanks, Reagan. Thanks, Amanda. And as we close out here for our audience, you'll see I did launch one final poll. If you were with us at the top of the hour, you may recall we asked you a question about how sustainable you feel your health plan strategy is. We now have a similar question for you. We are curious about, as you look towards 2027, what level of disruption do you think your organization would realistically consider for its health plan? So we see lots of you responding already. Please take a moment and let us know how you are feeling as you look ahead towards next year already. And as you're doing that, I will remind you, we did record today's session. A link to the recording will be available early next week from that benefits advisor who invited you here today. Again, that's a common question we get. So if you are looking for a link to the recording, check with that benefits advisor who invited you here today. They will have that the first part of next week. And again, as Reagan mentioned, if you do have any follow-up questions or just want to really dig into any of this further, that benefits advisor would be a great resource to do that with. And again, we would like it to extend our gratitude to those benefits advisors and consultants who are partners of Assurex Global for making this webinar series possible. And we are getting a couple more responses in. I'll let those trickle in here. It looks like, and I don't think I'm surprised here. I think most folks still only kind of have an appetite for some minor adjustments, maybe some minimal copays or deductibles, maybe some small contribution increases. We're about a little over half of you are feeling that way, with about a third of you feeling maybe some moderate changes may be in order. But I know we're still early on in the year here, and those things can certainly change. I'll share those results out here so you all can see how your peers on the call responded. So there are those. And I think you all may be aware we do publish these full results in what we call our market check surveys. Those come out every month based on these polling questions. So if you'd like to take a closer look and kind of get our thoughts on these questions, those come out usually within about a week of these webinars. But again, thank you for joining us. That does conclude our time together, and we hope you all have a wonderful afternoon.